Well, welcome everybody. Our presentation tonight is about contact tracing, and we're going to present an integrated model of consumer perceptions towards contact tracing for COVID-19. This project is done by myself and Avi Mukherjee, whom you all know, and and our other author is Christophe Mukherjee, who's at the Joan C. Edwards School of Medicine. So it's a good mix. Avi's a marketing professor, and I'm an accounting professor. So it's a good mix of people on this project. Here's the outline for what I'm going to talk about in about 20 minutes. I'm going to give you a little background, talk about some of the managerial issues with contact tracing. I'm going to talk about a prior research study that we've done, which I'm calling Study 1. We'll talk about the theory base, a proposed model, and then our new methodology, which includes measurement items, scenarios in the sample. All right, so contact tracing, you're all probably really familiar with it now, even though probably a year ago, I know I hadn't heard of it or known exactly what it was, but it's a data-driven and effective public health strategy. And the goal of it is to stop the spread of a communicable disease like COVID-19. It's been actually used for many years and for many different communicable diseases. I'll talk on my next slide about how it works, but contact tracing can be done manually with human intervention. That's how most of us have seen it, but there's also digital solutions and hybrid solutions that use a combination of human and digital technology. All right, so contact tracing, the steps are, and actually the one up here and the one down in the slide on the right are a little bit different. On the slide on the right, it says someone actually gets the disease, COVID-19, and tests positive. And then what happens is we come up here to number 1, where you interview people and that person who tested positive and try to figure out who they've been in contact with. Step 2 is notifying the contacts that they've been exposed or potentially exposed. And then you try to solve their issues in terms of, do they need testing? Do they need other help? And monitoring them for symptoms and making sure they self-quarantine. And that's how the spread gets stopped. So that's a little review. Contact tracing, again, it's been used for a long time. It's also been used internationally in a lot of different forms, you know, whether it's just tracking people who get the disease or actually trying to locate those contacts. It's, again, been used in a lot of different ways. And just recently, many companies were using it. All right, so some of the managerial issues, which makes it a good fit for SAM, is that a lot of back to work policies when late last summer, when companies were starting to try to go back to work, involve contact tracing. However, a couple surveys were done showing that maybe the employees might not have been too happy about it. In that second bullet point, I have 75% of the people surveyed said that they wouldn't allow their company to trace their contacts. And another survey by PwC showed that only 35% of workers wanted employers to use contact tracing. So that got us thinking about, well, what are people's beliefs and perceptions about contact tracing? So we did a study, a focus group study, that was really a qualitative research approach. We used a grounded theory method and a design thinking approach, which again involved customer empathy interviews, where we really tried to get at how people were feeling about COVID and disease spread and contact tracing. That study, we took what people said and then we coded it according to the rules behind grounded theory. And I have some examples on this slide of some of the things people said and how we coded it. For example, in the first one, someone said, I remember thinking, 1, we don't know how dangerous it is, and 2, it's a real inflection point, things will change. And we thought that that showed that people felt very vulnerable. You know, they weren't sure about the disease at that point in time. We did these last summer, and they felt like, gosh, am I going to catch it? There's just a lot of uncertainty around the disease. Another example in this second line that says adjustments, someone said taking precautions is a burden, but hasn't ruined my life, but my life has changed. So adjustments we made as a category for people who talked about all the social distancing and other preventative measures. So those are a few examples. There's many, many quotes we got. We did 3 different focus groups with different cohorts of people and found out many interesting things about their beliefs and perceptions. So what we've done since then is we took that and we said, okay, can we match up some of those categories and codings with some theory to give us a really good, solid theory base in this research? And this first model that I'm showing is the protection motivation theory. And that's used a lot of times in healthcare. And it describes what motivates individuals to protect themselves from harmful situations. And again, a lot of times it's used in health behaviors. It's been used in information technology security type research. And we saw some of our categories that we had coded in this model. For example, the vulnerability, you see the second box down, and the bottom 2, response effectiveness, again, in terms of if I social distance or wear a mask, is that going to protect me? And then self-efficacy, we also saw. So people had talked about how confident they were that they could actually do these preventative measures. So we thought that this was a good theory base for our research. We also looked at the theory of planned behavior. We saw a little bit that people were mentioning this idea of subjective norms, what other people think they should do, if other people think they should participate in contact tracing or not. We also tapped into their attitudes. There was a lot of positive and negative attitudes over contact tracing. We had a whole part of the session that asked the focus groups about what they thought were the pros and cons. And then the bottom big construct here, perceived behavioral control. And that was in terms, again, of their self-efficacy and of facilitating conditions. So they were concerned how easy it would be to use contact tracing in terms of, is it going to work on all phones? And, is there going to be support if you have questions along the way? All right. Our third theoretical base is the privacy calculus model. And this is a model, I'm familiar with it. I do some research in the MIS field. And so when you're talking about disclosing personal information online, this model really comes into play. And the part of this one that we saw are the perceived privacy risks and the perceived benefits. So again, a lot of people talked about, giving up their personal information. Some of our focus group was okay with that. They said they didn't have anything they wouldn't want to hide, while other people focused on the benefits, that using contact tracing would help other people. All right, so together with the coding that we got from the focus groups and review of theories and identifying the theory bases that matched up with that, we come up with this proposed model for contact tracing. And you can see it has 3 parts to it. It has the antecedents, which are the disease beliefs, the adjustments, prior knowledge and experience, and personal emotions, which we got a lot of. Those focus group interviews were just really rich. With people were raw about COVID-19 and staying at home and quarantining. And we feel like we got a lot of data that you just couldn't get now that it's been a year. And so the personal emotions really came into play. We have the middle box here that were the beliefs and perceptions. Again, those risks and benefits, the facilitating conditions and subjective norms. And then on the far right are the consequences, which would be both the intention to participate in contact tracing and then the intention to disclose their personal information. And those kind of go hand in hand. So we have both of those in the model right now. Okay, so our next step was to collect measures for all of those. So my next big bunch of slides here are the measures we picked up, and some we've had to develop, and I'm probably going to just go over this lightly, but in the disease beliefs, we were able to get the perceived severity of COVID-19 and the perceived vulnerability of people to COVID-19. And again, that comes from that prevention to protection model. Then we have some of the adjustments, and those include those efficacy. So how well did people adjust, and how well were they able to adjust to some of the preventive measures? We feel like that will influence their thoughts about contact tracing. And then at the bottom, I have the attitude towards the preventive measures. Okay. Then we have prior knowledge and experience, and some of these I got from prior research and some were newly adopted, the experience ones. But we want to know how much prior knowledge they have about the disease itself and how much prior knowledge they have about contact tracing. And we felt like that really came out in our interviews. At the time, not everybody knew exactly what contact tracing was, and some people had participated in it and some people hadn't. So we think both knowing about the disease itself and about contact tracing would be important. Personal emotions, again, that came across really strongly, and we found this perceived stress scale, and this will have to be modified a little bit still because it says in the last month, and we'll want to scope that as to the timing of our survey. But it kind of gets at people's stress levels with what's going on. So this is a well-known scale by Cohen et al., and it's been used in a lot of different health-related studies. Then we have our risks and benefits, and the risks that we picked up come from the privacy, concerns for privacy risks, and there's a battering of them. One, like on this slide, you see collection and errors. And these were all things that people talked about, like, you know, is the information going to be accurate? Who's going to be collecting it? Will I trust them? Here you see secondary use. Are they going to sell my information or give it to people who shouldn't have it? And hopefully that only the people who really need it would have access to it. So you see some of those risks. And then on the benefit side, we have just a newly developed overall benefits, and then some personal benefits and societal benefits that we found in prior research. And these all relate directly to contact tracing, whereas some of those antecedents had more to do with the preventative measures. Okay, then we have facilitating conditions, and this is the typical scale that you see about facilitating conditions and the resources. Subjective norms, again, that's about, do my peers, people I know, my superiors think I should participate in contact tracing. Then we have the two dependent variables, intention to disclose and intention to participate. And the last one, we needed to adapt a little bit. Okay, so those are the measures we found. And so far we've come up with two main hypotheses. And while I don't really state the hypotheses here, they're going to have to do, the first one is with social presence. So our hypothesis will be that there will be a difference in results of that model when we're talking about digital versus manual contact tracing. And the idea is that that is because of social presence, which is the ability of communication media to transmit social cues. So in prior research, they classified media as to how well it conveys that personal touch or intimacy and warmth between users. So in other words, in this scenario, digital contact tracing would have less social presence than manual. And that was a big concern of people. Most of our focus group, it kind of went half and half on which type of contact tracing they would like, but a lot of them mentioned that personal touch. So we brought that as our first hypothesis. And then our second one is going to deal with closeness. And there's a variable that's used in the marketing literature called relationship closeness. And it's used when researchers are trying to figure out about, will people buy? Will they buy in groups of people? Like if you go shopping with a friend, is that going to affect your buying behavior? But there's a similar concept called work relationship closeness that's been used in the turnover research. And so we think that if we do this in terms of a work situation, that we could use that concept of work relationship closeness. There's also a related literature in, I've actually used it when I have done some research on social media, and it's called Network Ties and Social Capital. And that research talks about the strength of your ties. And if your ties are very strong, you can develop this bonding social capital, which means, it's like you've done something with these people, you know them, you bond with them, versus bridging, which isn't a bad thing. It just means that these are people that you don't normally connect with. And some advantages there are that you might learn some new things. So this is the hypothesis that the model will predict better if the closeness, if you're closer with the person who's undergoing the contact tracing. And what we're going to do is we're going to use a scenario-based survey and give people scenarios to read about contact tracing events. And scenarios have been used in the literature because they can help respondents focus on a certain situation, and that brings control to the study. And it's also very non-intrusive. You're not really asking them about themselves, you're asking them about the person in the scenario. So with, for example, socially, with behaviors, certain behaviors, it's easier to do it that way than it is to ask the person personally. And it also makes them, because they're answering about somebody else, they're not just going to answer the way they think you want them to answer. So that's why we decided to use scenarios. And I have 2x2 on this slide that shows we're going to manipulate social presence to be low and high. Again, virtual, low social presence would be digital, and high would be the manual contact tracing. And then closeness, will either have close or not close individuals in the scenario. And so we'll have 4 different scenarios. You can see on my little blue tab down here that some of the different contexts we might use are like a household, that would be relationship, that would be very close, versus like a conference like this might be less close, work environment might be in the middle. So we want to manipulate that, vary that to see if that makes a difference in our model. We're going to use in our sample, we'd like to have professional employees be our sample, and we'd like to have some of them be healthcare employees, because we had some healthcare people in our focus groups, and they seem to have very different answers from some of the other professional people we had in those focus groups. So we think that there might even be somewhat of a difference there, although we will be controlling for experience and knowledge. So that is our presentation. I think I finished a couple minutes early. So I'm going to stop sharing.
Any questions?
And
so Nancy, just a quick couple of questions I have. One is, I know you mentioned about the sample that I'm hearing my echo. I can't hear properly.
Nancy, can
you want me to
so,
talk about this?
So my question is, there are two questions. One is I think you said you will be looking at the health professional. But what about the other professionals, like those who are in the service industry and those who are in the product industry? And there are two different groups. And then the second question is tied to the political party affiliation, that we have been seeing lately, that we have two distinct groups. So will that have any moderating effect on your results? So type of political affiliation and the service type of work versus regular work that we have.
Yeah, I think both of those are good points. We didn't think about political affiliation, but definitely the work groups, there's, depending on the sample size we get, we'll be able to split it up, but we should definitely see service and product, because in our focus group, we had some people who worked in the manufacturing sector, and they were really on top of contact tracing because they needed their employees to come into work and be working during that time.
Yes.
And they didn't have as much stay at home as some of us have had. And so that was very interesting that they were almost as on top of it as the healthcare professionals. Wouldn't you say, Avi, that's what we had?
That's right. Yes. So we, your point about service versus product, I think we can build that into our continuum from household all the way to like a conference. We were talking about that continuum of closeness and so on. And the fact that in most digital, well, we can say manufacturing people have to come together and work in most cases in factories and all, but there are some services that are emergency services, people have to be there as well. And then there are digital services and so on where people are working from home, and therefore they are separated out. So but that's a very interesting point, and definitely the context of their work makes a difference.
Okay.
Yeah,
and now the timing will vary, right? When you do your survey, is the timing going to affect the same people you survey, let's say 3 months from now? Will their result be different?
Exactly. I mean, things are changing with regard to this altogether, right? From the perceived severity and the perceived vulnerability, perceived seropositivity.
Yes. Okay.
So
yes.
Yeah, but we do want to make this bigger than COVID, of course. The context is COVID for the time being, but for any pandemic, for any of any kind, these are useful. So this, I mean, contact tracing has been used all the way from AIDS to plague to all kinds of other diseases.
Thank you.
Yeah, thanks for your question. I was also going to add that work relationship closeness scale has been used a lot in the manufacturing. So when they talk about work close, that's where I found it. It was a paper about a manufacturing plant. And so they were getting at, did the employees feel close to the managers? Did the managers come down on the line and talk with them a lot? So that's interesting. Yeah.
Thank you.
Thank you.
Yeah.
I think we also have a question in the chat.
Yeah.
It says, do you think that the way contact tracing is going is working efficiently? So I don't have first-hand information. Whoops, I'm echoing a little.
Yeah. Susan, can you mute, please? Yeah. Okay, now go.
Okay. I don't think that digital quite worked the way that was originally thought it was going to work. I know that some states tried it with some, from the public health viewpoint, some states had been trying it, and they weren't getting that mass of people that you need to be effective with it. Some sources say that has to be 60% of the population has to engage in it for it to be effective. I've seen less, I've seen more. I think 60% is about what is kind of commonly looked at. So in terms of digital, I don't think it got to where they thought it was going to get, but certainly the manual worked, I guess, in terms of helping out as best as they could. I know here at Marshall, there was a lot of contact tracing going on in our town and our healthcare system with our public health. And, it was invaluable to have that. Uh, so I need to look into it more to give you the exact answer to that. But I would say, yes, the manual did work efficiently. Now it's very expensive, and that's why they've turned to the digital, right? Because it takes a lot of people to do that work and to make all those contacts with your contacts. And it can be very expensive. And, in the beginning, they were giving estimates of how much money that would cost states, and it was really high. So that's why they were originally, Google and Apple put out apps for the digital, because they were thinking that that would solve that problem.
One of those things I was reading about the NCAA is that the reason why a lot of the games, sports had to be canceled in NCAA was not because a few players got COVID, but because contact tracing failed. I mean, it was very
Ah,
interesting. Those two players could have been taken out, but the whole system failed so badly that the teams had to be off for weeks sometimes, and the season couldn't go the way it was planned initially. So, contact tracing is so important, and it is so hard in so many ways. And
yeah,
many countries they went in the digital route, but obviously here that didn't happen as much, and it became harder also in some ways. But I can see why people like the human contact, because there is a degree of empathy attached to it. When somebody calls and speaks, it's not, you don't want to read like on a machine on the smartphone that, oh, I have, I might have a chance of getting COVID. That's, nobody wants that. And so there, that factor came a lot in the focus groups.
Yeah, but I mean, if I may, one of the things that is important is 1 hour, missing 1 hour of, initiating the contact, you are dealing with another set, and the number of people exposed grows exponentially by those. So, I mean, we had classes where, for classes, we have seating charts so that we know exactly who is exposed to whom. But if that seating chart is not updated, the person who is doing the contact tracing, reaches out to the faculty, and even sometimes 5-6 hours exponentially increases the number of contacts, and as a result, at some point they have to just put whole classroom in the quarantine, because there's no way you can do. And even with that, sometimes the number of people exposed is growing so many that you have to shut down some stuff. We had one issue with our athletic department, and as a result of that, because that student happened to be in dormitory, that basically exploded in one of the weeks, and we had many cases as a result of that. Just one case lead to, let's say, 64 other people exposed.
Great.
Very interesting topic.
Thank
yeah.
you.
Thank you. Thanks for sharing that.
It is 6:31, so I guess if there are
Okay.
no other questions, we'll wind up and we will head out to the reception.
Okay. Thanks everybody for your questions.
Thank you very much. And please submit more thoughts and questions on the social media through WUVA,
Okay.
even after the presentation. Thank you. Take
Yeah.
care.
Okay. Thank you.